Test 1, 2, 3. Test 1, 2, 3. Test 1, 2, 3. Hear through that, that's fine. Okay.
call the order to the Board of Managers meeting on this date, 11 February 2021. We're meeting virtually as directed by Governor Abbott of the great state of Texas. And I do not have to call the roll, but we do have a quorum, if I'm correct. Is that right, Daphne? Looks like we do.
That is correct. We have a quorum.
Okay. And with that, I'd like to have the opening prayer and the pledge. And I see Leanne Franklin there.
Hi, everyone. Will you pray with me? Loving God, on this very cold day, we pray for those who have no warm place to be. May they find warm refuge. On this treacherous day on the roads, we lift all those who've been in accidents and those who've witnessed accidents. May they find healing. For those who are caring for the injured, may they find strength. For those who continue to be on the front lines of patient care, may they have protection and perseverance. And for all those in this virtual room, everyone who's committed to making life better for our patients, our families, and our community, in a time that health and healing is needed more than ever, may each one of you receive wisdom, grace, and rest. I'm going to add one more request. May you all experience joy in the midst of all the challenges. The work can seem endless, I know. May each one receive exactly what you need to continue being the light that you are. All this we pray in your holy name. Amen.
And to the republic for which it stands, one nation,
under God,
under God,
indivisible,
and justice
for all.
It's tough for me to hear various folks with that. Any citizens wishing to address the board? I can't hear anybody.
No citizens addressing the board, sir.
Okay, thank you. Next item is item 4, which is the approval of the minutes, Board of Managers, the 10th of December, 2020. I'd entertain a motion for approval and a second.
Chuck, there be no discussion. I'd recommend approval.
Okay.
I'll second.
Is that Steve Simmons?
Roger Fisher, second.
Okay. Any discussion? All in favor, please say aye. Those opposed say no.
Aye.
Aye.
All righty. Board chair report. It's going to be similar to my past ones, which is thank you for all the people that are doing all this work. Our thoughts and prayers certainly go out to all those family members and anybody else that's been affected by this nasty COVID-19 virus. And with that, that's my report, and it's up to you, Robert, CEO.
Thank you, Dr. Weber. I appreciate it very much. Let me give you guys an update on a few items. The first thing that I wanted to tell you is obviously the weather is playing a great role in every one of our daily lives, but particularly at a healthcare network. That you got to keep clinics open. You got to make sure that you're the one that is 24/7. There are some people who will see weather like this and think a fireplace and a good book is the perfect thing to have, and it is, but not when you're at a health network. It's sort of all hands on deck. We went ahead and started our clinics at 10 o'clock this morning because we knew the weather was going to be a little bit difficult. We are preparing for what is going to take place potentially on Sunday and Monday, being some of our coldest time, and some of the time that we might get precipitation, it might snow, we might get some ice, and then is the problem we had this morning with the black ice on the highways. The only thing that I feel fairly good about regarding the strange Texas weather is a friend of mine that helps me out with horses called me this morning. He lives in northern Minnesota, and he said it's minus 40 at his farm this morning. So I felt pretty good by the warm front that we're about to hit on Sunday compared to northern Minnesota. But Karen Duncan and the operations team and Adam Lane and Angie Morgan and the folks that are making sure that our clinics are open, make sure that if you can't get to a clinic, we have telehealth available to you, is a nonstop, unbelievable diligence on behalf of good people. And my thanks to Karen and Adam and Angie and the facilities team and our transportation team that are helping people get to where they need to get to. So inclement weather, we are as prepared as we can be, and we will be nimble as we go forward. And Dr. Miller and his team are certainly prepared for what might be coming through the door from an accident situation or the unfortunate situation we found this morning on I-35. And for those of you who didn't hear, we had about 16 patients come into the emergency room this morning from the accident on I-35. We had 4 of those that were employees. 12 of those 16 have already been discharged. Again, when you're a level 1 trauma center, you are up for the call. And Rick Miller and his team were exactly what you need in that time period. So very, very proud of them. The other thing I wanted to give you all an update on is the executive team is beginning to go back to our process of rounding, going back to floors and seeing our nurses and our patients and talking to them. We started that up 2 weeks ago, and it has been very welcome. It is that attempt at normalcy that people so appreciate. So our team has been quite thankful, doing the basics like writing thank you notes, doing that, what's happening on your floor, what can we do to help you, what can we do to improve things, what can we as an executive team do to listen to you and what you need. That has been the strength of the culture of JPS, and COVID-19 is not going to stop us. So we have continued to do that. I'm very proud of the executive team for their willingness to don protective eye gear, masks, and anything else that it takes as we go rounding through the hallways and through our clinics. I'm very proud of the team. The other thing that I would let you know is that tomorrow we as an executive team are going to have a strategic planning retreat. Lauren Poe, who you'll meet a little bit later, you've already met Lauren, but you'll see a little bit later as she talks about our community need assessment. We're going to get together and talk about our strategic plan. A lot of our strategic plan is based off of the interviews that some of you, many of you had. They're based off comments that we've had. And what we will put together is basically a preliminary design. We will be bringing that to you as a board in a very formal way, in a very structured way, for you to be the ultimate deciders on that strategic plan. We hope that we're giving you a text that you can edit, alter, change, and rearrange. We think we do, as a staff, we think we do you a disservice if we're not giving you what we think might be a direction in hopes that you will either strengthen that direction, amend that direction, or say, yep, you're right on target. But that is a very organic document as we bring it to you. But I did want to let you know that we are spending our day tomorrow in a retreat-like setting, going over everything piece by piece, word for word, which will make a better product coming to you. The last thing that I'll mention, and Dr. Miller is going to go into a little bit of this, but I got a text from Amanda Arazola, which I appreciated very much, looking at the challenges that the county was facing with vaccines and longer lines and where should we go and what should we do. JPS now, through the good work of Joy Parker and Doug Chung and Jill Farrell and some of our other team members, have really done a fantastic job at putting JPS in the right place for vaccines. We don't have the ability, and you all realize this, we don't have the ability to take a nursing team and put them out in the community and help out in some of those, the mega centers. we're not going to have staff that are going to be able to go to the motor speedway or go to some of the other locations that UNT is now set up with their efforts for the county. But what we are doing is we're taking a portion of the long list of people that are in the queue at the county, and they are coming to JPS to get their vaccines. And that has worked very, very well. So JPS is pretty much hit its norm at giving a little over 1,000 vaccines a day. And if the state will supply us with vaccines, we can keep that up. If we went to 1,500 or 1,600 or 1,800 vaccines a day, we couldn't do it because of our facility constraints, and we couldn't do it because of staffing constraints. We feel that our special area of providing vaccines is to literally about 1,000 people a day. And those come from a multitude of factors. One, our employees. Any of our employees who have folks that fit a 1B category. Also, inmate population. Trying to provide the vaccine for our county jail and making sure that that volatile population is taken care of from a vaccine standpoint. Also, what we do at True Worth in taking care of the homeless population. And I think we're being very effective at getting vaccines out to the homeless population. And then our fourth category is going to be our primary care doctors calling our most challenging patients from a standpoint of the highest levels of risk. We have focused on our clinics to do that, particularly in Stop 6 in our Como areas, our Diamond Hill areas, and even in our Arlington facilities. And that emphasis has allowed more of our higher risk patients to get their vaccine. So Amanda, I very much appreciate your concern for our community and what role JPS can play. And I think JPS has worked exceptionally well with the county. I think the county would tell you the same thing. And now that they're going to work with a partnership, the county with UNT in those mega centers, that seems to be the way that they feel is best. You probably read in the paper that FEMA has chosen 3 sites in Texas, one at Fair Park in Dallas, the AT&T Stadium for the Tarrant County and Western area, and Houston area for mega centers where more vaccine will be coming in. And that's not, according to the judge, at any lessening of what we currently have. It will just be more from those major centers coming out of AT&T, Fair Park, and the Houston area. So Texas has been blessed with a very strong FEMA effort, and I think that will be very beneficial for us. So I applaud our county commissioners and our county judge. I had a conversation at 1 o'clock with Commissioner Brooks, and he was ecstatic because he's worked really hard at working with UNT and trying to make sure that we're getting to not only our vulnerable populations, but a process of getting those vaccines into as many arms as we can get into. Reverend Emerson, I want to tell you, I appreciate you by setting an example by allowing folks that might have had a hesitancy to get a vaccine and allowing your colleagues in the areas of ministry to set an example for their congregations. So not only is it a message from the pulpit, but it's a message from somebody's arm. And you set an example, and so did many of your colleagues, to some of our population that might be a little bit concerned or not wanting to sign up for the vaccine in the numbers we had hoped. And your effort and the efforts of many of you all on the board don't go unnoticed by us. So we are thankful, and I know that many of y'all are trying to do the same thing. I had the ability to sit down with DT. We talked about the Vietnamese population and some of the vaccines that were going out. That too is a population that can be a little bit concerned about where we're going with vaccines. And I know each one of you have done a good work. I've had numerous conversations with Zim. Zim called me almost the first week COVID hit and talked about those who were homebound, those who were in assisted living and care facilities. And he allowed me to be a mouthpiece for the county to expand those services to a lot of those people in those areas. We got a long way to go, Zim, but your efforts were valiant as we tried to figure out how to get it to those populations. So from vaccines to executive rounding to preparing for the weather that we're having and our overall strategic plan, which we will ultimately get to you. I think we're in good shape. I'll answer any questions, but before I answer questions, I will tell you that I did not give you updates on COVID per se, because Dr. Miller is going to do that. And I will tell you, Dr. Miller, in his role as our Chief Medical Officer, should make you as a board member proud every day, because he's doing an exceptional job in a very short period of time. And I think he has taken on that issue, and he and I, because of predominantly my schedule, have not even really had the opportunity to talk about all the constraints and confines and how he does things. But he has grabbed that bull by the horns and he's running with it, and it's not running with him. And I appreciate that fact. So if you all have any questions of me, I'm happy to take on those. But Dr. Miller is going to present to you all the COVID update so you can get a perspective on that. Dr. Weber, that's all from me unless y'all have questions.
I have not so much a question, Mr. Chairman, as a comment.
You play it. Go ahead.
Thank you. So when I began my board service in 2015, I made it a mission to practice what I preach, so to speak, and get my medical care, my personal medical care at JPS. It has been by far the best medical care than I can ever even imagine. I found myself over the New Year holiday coming down like millions of other people in America and across the world with COVID-19. You know, thank the Lord, my case was bad, but not as tragic as many others. We're very blessed by that. But I was also blessed with some very, very good medical care from JPS. You know, granted, I didn't have to wait in a line or sit in a waiting room, and I understand that. But the care and the compassion and the follow-up phone calls from the automated system that JPS set up has just really been truly remarkable. It's a story that I felt needs to be told, at least at this level, but it's a story that needs to be told more and more throughout the days and weeks. And once the pandemic's over, the care and the doctors and the nurses and the medical staff and the administration, everything that goes into making JPS a special place. I'm grateful for it. Happy to say I'm pretty much recovered. I told David Mendenhall early on the call, I said, too much chagrin, I'm still here, but it's by the grace of God and by really fantastic care at JPS that I'm here tonight. I'm forever grateful. So thank you.
No, it's great. You're just emphasizing one of the things that I've known for a whole lot of years. Great care at JPS.
Mr. Fisher, I would disclose that when you came in for your care, we did put a monitoring system on you, and I would encourage you that you are still a COVID recovering patient, and playing football with your children is not a good idea at this stage. Just saying, don't do that.
No, that's true. It still takes a little bit out of you, and I probably set recovery back a couple weeks last weekend playing football with the boys, but it was a good time. But I paid for it the next couple of days.
Well, this is, you know, more like, I feel at home here with this temperature. I think we should all be playing hockey outside right now, not football.
There you go.
It's going to get into single digits on Sunday and Monday, which just makes me feel right at home here in North Texas.
Yeah, that's crazy.
Go ahead there, Rick.
All right, thank you. Thank you, Chairman Weber, and I'm very happy that you're recovering, Roger. I have been so impressed with the team here. As you know, I've been a trauma surgeon for over 30 years, and we've networked with the medical folks in the COVID ICU, and there is no better team than right here at JPS to manage this very, very challenging pandemic. What I'd like to do today for the board is show you a little bit of an overview and get you to see where we're going from here. And there is good news and there's potentially some bad news. Next slide, please. So as far as JPS goes, and I've been in touch with all the CMOs in the DFW area, and this is pretty consistent. The good news is that the COVID numbers in hospital are going down, and we do project a reduction in the number of patients that are admitted to the hospital over the next several weeks. Right now here at JPS, we have 115 patients in the hospital, and in our ICU, we have the COVID ICU, which is a 30-bed hospital center, open unit. We have 18. Our highest was almost 30. I think we had 29. So that was reaching really high capacity. The census in the COVID ICU lags behind the census in the hospital, primarily because these are really sick folks and they tend to stay in there for a long time, some up to 3, 4, or 5 weeks. And unfortunately, once you're on a ventilator, your mortality rate goes up significantly. We reached the unfortunate 250 death rate today at JPS. The other good part is because the numbers are going down and because we have very good PPE, we have opened up our visitor policy and are allowing family members, at least in restricted numbers, to see our patients all throughout the institution. And this, we believe, is very important for the overall patient care. As far as surgery goes, we have opened up outpatient elective surgery only so that we don't overwhelm the system with any admissions for surgery. That started this week with all of our operating rooms opened up again, and we're getting through the depot of elective surgery. The only problem is the depot of elective inpatient surgery is growing, and this always potentially increases our chances of people getting sick from low back pain, from complex hernias, and other illnesses that we just can't get to right now on an elective surgery base because they have to be admitted to the hospital. Next slide, please. So I wanted to go over a little bit of information on all of the vaccines that are out there right now and explain exactly what each vaccine does. The ones that are available in the United States and the ones that we're utilizing here in the DFW area right now are messenger RNA vaccines, the Pfizer vaccine, which is 2 doses 3 weeks apart, and the Moderna vaccine, which is 2 doses a month apart. Both of them have about equal efficacy, which is the highest that we've seen so far for vaccines, which is about 95% efficacy. The feedback we're getting on folks that are getting the vaccine is the first vaccine seems to be very well tolerated, but there is a lot of variability in the symptoms that people get after the second vaccine. It could be mild, or it could be a really bad viral illness like cold with myalgias, headaches, muscle aches, and chills. We've asked multiple people, and it's all over there, all over the range of these symptoms, and we just don't know why some people get it higher incidence of symptoms and others don't. There's 2 other large-scale phase 3 clinical trials going on right now with what we call viral vector vaccines. And what the viral vector is they take the attenuated adenovirus, which is the virus that causes the common cold, and then they join it with a component of the COVID-19 vaccine, and then give that vaccine. The 2 are AstraZeneca, and the interesting thing about AstraZeneca, which is coupled with the University of Oxford in the UK, is that these 2 doses, the recommendation is to give them up to 12 weeks apart, because they found if you gave this vaccine in less than 6 weeks apart, the efficacy was only 54%. But if you increased it and up to 12 weeks apart, the efficacy went up to 82%. The one that everyone is talking about is Johnson & Johnson Janssen, which is the advantage is it can just be stored in a refrigerator, a plain old refrigerator, and it's only a single dose, which I think in certain patient populations may be advantageous, especially folks that we're not sure about their follow-up. The only thing right now is it may be a little less efficacious than the 2 doses with Pfizer and Moderna. The last vaccine that is being investigated is out of a company in Maryland called Novavax. It's also 2 doses, 3 weeks apart, has very good efficacy. And this one is a kind of a unique thing in which they just take a subunit of the Corona-19 vaccine, attenuated so it doesn't cause significant symptoms, and inject it. So it's different than all of the other vaccines. Next slide. So as I mentioned, I meet almost every week with all of the CMOs in the surrounding area. And as I said, the hospitalizations for COVID-19 are going down. And the reason they're going down are primarily 3 issues. One is herd immunity, where a large amount of the population has gotten the virus, has recovered, and is doing well, just like Roger had mentioned earlier. And the other thing is we are increasing the number of vaccinations, although this is going to be a long period of time before most of the country, hopefully at least 70% of the country, gets vaccinated. But the addition of the 2 main monoclonal antibodies going on right now, we've actually given over 400 doses of the monoclonal antibody, which has now been shown to significantly reduce the severity of the illness, the number of patients that are getting hospitalized, and the number of deaths. So the combination of recovered herd immunity, vaccinations, and monoclonal antibodies, and the great care that we get in all of these hospitals, is hopeful that we'll eventually recover from this disease. Now, there is some evidence right now that at least viral shedding is decreased, and thus potential decreased transmission of the virus with the vaccines, which is really exciting. But it is very early in the data, and we're still not sure, even if you're vaccinated, whether or not you can give the virus to other people. And we'll talk about that in a second. So as I mentioned, J&J, single dose, regular refrigerator, and we may want to think about utilizing this in special populations, especially the homeless or correctional facilities. So public health mitigation strategies are still essential to limit the spread of this disease. And so encourage vaccination, encourage physical distancing, utilizing masks, good hand hygiene, and isolating and quarantine. Now, the one last thing that I want to talk about is what folks in the area, especially the ones that are doing all the data, is concerns about these COVID variants. Next slide, please. So there are now 3 relatively new variants to the Corona-19 vaccine. The most prolific of which is from the United Kingdom, the B117. This was data that I obtained on February the 4th when I had to get my slides in. There were 611 cases. Now there are 1,000 cases of the UK variant in the United States. The newer variants, the one from South Africa and Brazil, are still in low numbers. But the big problem with all 3 of these, primarily in California and Florida where we're seeing these, is that they all seem to spread more easily and quickly than the other variants, which may lead to more cases and a potential surge again in 4 to 6 weeks from now. So far, studies suggest that the antibodies that are generated through the vaccine with the ones that we authorize, do also recognize these variants, but it's still early to tell. So the good news is our numbers are going down. Our therapy and vaccination help. The bad news is that there are variants, which are very common with viruses. Some come, some go, some stay for a while. We still don't have enough information to know whether that's going to cause another surge, as well as spring break coming up in a few weeks, that we might see an increase again. So that's my report to now. I thank the board for allowing me to distribute this information.
Anybody got any comments or questions for Rick? I don't hear anything, Rick. Thank you very much for providing the data for us.
Very welcome, Chairman.
Okay, the next is.
I have a quick question.
Yeah.
Dr. Miller, so the new variants, is it that they're more easily transmissible? Does that mean surface contact, or is it still an aerosol air thing, or is it both?
So the data we have so far, Roger, is that the vast majority of coronaviruses are spread by the oral cavity, and very little on surface spread, especially with good hand hygiene. Early on, it was thought that the COVID-19 virus could be spread quite significantly with touching surfaces, but with further data, that has not panned out. Roger, I'm not sure. It is very hard to detect and to identify the variants so far with the current testing that we're doing. And only specialized labs are able to identify the variants. So there's very preliminary data on it, but the coronavirus 19 in itself does not spread anywhere near as much by surface as it is by secretions and generation from aerosolized. So I'll always recommend a mask. The CDC is looking now, even if it's more efficacious to wear even 2 masks. So the data from that is coming up soon. So that's the best I can tell you about that right now.
Yeah, wearing 2 masks is what they may do where it's real cold up in Minnesota. I mean, we only need 1. I was the recipient of a very violent reaction to the second dose of the Moderna. I can tell you that it is not fun. I cannot see anything but the JPS powered by Pride slide. Can somebody?
That's all you have on the screen right now. It's transitioning to the next financial report. Yes.
Wait, I got item 8 is report from the Medical Executive Staff Committee requiring discussions, update, deliberations, actions, and/or approval. Cheryl, are you there? Cheryl Hurd?
Yes, I'm here. Thank you, Chairman Weber. I appreciate the opportunity to address the board. I don't have anything on a slide to present. I just do have a verbal update, kind of a high-level executive summary of what we've been doing over the last year. And I do have a little bit of numbers for you from some final year-end reports from some of our committees. So I do want to say that in our role as oversight of the quality of the physicians and providers who provide care at JPS, we do have performance including quality reports. So the patient safety quality governance do submit their minutes to the MEC for review and approval, which was done, as well as the PSI 90. In addition, the MEC did also review and approve the quality assurance performance improvement annual evaluation and plan that has been brought forward to the Board of Managers as well. Our Physician Excellence Committee annual report, and this is all for information, but I did want to read off some numbers for you. The total cases referred and screened by peer review specialists were 1,035. The total cases that met any Physician Excellence Committee indicator criteria for actual review were only 97. And of those, we had the following outcomes from the providers based on the care that they provided it was reviewed by a multidisciplinary large group physician excellence committee. So out of the appropriate findings, there might be more providers than cases because there's more than one provider on an individual case. 112 providers that were reviewed were deemed an appropriate rating, which means they met standard of care, even beyond. 21 were deemed what's considered inappropriate, which may mean that they either fell out of an indicator or they didn't quite fully meet standard of care or something additional happened. There were 7 that were determined to be what we call indeterminate, when there was really no ability to formulate whether or not there was outliers from the standard of care, but there was still some areas, what we call areas for improvement. It frequently occurs in documentation and communication in regards to medical records. There were no providers who met any rule breaks for the medical staff. There were no providers who tripped any thresholds for the number of inappropriate indeterminate cases reviewed. There was one just attending resident supervision rule break where the residents needed to inform the attendings of what they were doing. There were 51 referrals sent from the PEC committee to other committees. And there were also 12 different cases of exemplary care found by this Physician Excellence Committee, as well as 3 Strong Work Awards over this last year. In addition, the medical staff committees did review, and the Medical Executive Committee did review all the minutes and continued to review the minutes of the Medical Records Committee, ER Committee, and the Ethics Committee. In regards to education, the members of the MEC and the chairs of the medical staff committees were actually provided an educational session on December the 11th with our bylaws consultants. And it included a wide variety of topics, but it was a nice overview and refresher for medical staff, self-governance, peer review, and also legal aspects involving credentialing and privileging. It was very well received, and I also had a lot of requests for this to continue. So we're looking at if at least doing it biannually, perhaps even beefing it up to quarterly as we continue to have more interest. And then finally, I've teased about the bylaws for a while. We're bringing those forward to the governance committee soon. But the bylaws committee and the subcommittee with the consultants have actually worked through articles 1 through 7. And those include purposes and terms, membership, categories of membership renewal, clinical privileges, evaluation and corrective action, hearings and appellate reviews. And we'll be bringing those articles to the Governor's Board for discussion. All voting on the entire articles will take place subsequent to the active staff vote, which we hope to have done in April. So that's my report, and I'm happy to answer any questions.
Great. Thanks, Cheryl. Anybody got any questions for Cheryl? I don't hear anything. Cheryl, tell the medical staff once again, thank you very much for all their hard work.
I will relay that. Thank you, sir.
Thanks. The next thing is item 9, committee reports and action. First one I have is Planning Committee, Trent Petty.
Yes, sir. Thank you, Mr. Chairman. We did meet in January. Adam filled us in on the process relative to the capital projects that we discussed at the board meeting and at the Planning Committee meeting. Also, the process that we're using on the IRMA in terms of the overall maintenance effort. The chillers are being replaced. Adam's making a lot of progress. So we've had some discussions early on relative to the bond progress. Brought us, I think we have that process now moving forward. So nothing of any action that the board would need to address, but we did have a good meeting. I appreciate everybody's attendance.
Thank you, Trent. Anybody have any questions for Trent? Don't hear any. The next one I have is B, which is the Quality Committee. We've met twice. We did not have any PSI 90 update data, and Rob was kind enough to give us at that time the COVID-19 update. We also had a detailed presentation from the sound physicians that I hope answered most of the questions that people may have had. They're hardworking people, hardworking physicians and physician assistants, and they've been with us for 10 years. Next one I have is Finance Committee, Steve Montgomery.
Thank you, Mr. Chairman. Finance Committee met on January 28th. I think most everyone on this call was at that meeting. You all may recall that we budgeted for FY21, anticipating slow return of volumes, and that's pretty much tracking what we're witnessing. It's maybe a slight bit slower than we budgeted for, but it's hopefully trending in that direction. We exceeded our budget in terms of operating margin by a good amount, probably 30% over what we anticipated and what we budgeted for. And our net income was obviously much higher as well. A claim, similar kind of trend. We saw our actual loss much less than, or about $1 million less than what we budgeted our loss for. And I'm speaking specifically about December. And then our total operating revenue is up with a claim was up about 4%, with our expenses being down or lower by about 6%. So we seem to be trending the way we hoped we would. Sharon gave a pretty good overview of November, December financials, and she can answer any questions you may have on those. We also forwarded for the board's consideration several contracts that we'll hope that you favorably consider. I think they're on a consent agenda, and that's my report.
All righty, thank you.
Sure.
Questions for Steve, anybody? Hearing none. The next one is D, Human Resources, Dorothy DeBow. We got Dorothy?
He was there.
I just had to unmute. Hi, we met on January the 24th. We had a not such a lengthy meeting. We covered policies and the executive cut. We have a few policies on the consent, and we are bringing forth a recommendation to our pension plan. That's my report. Thank you.
All righty. Questions for Dorothy, anybody? Hearing none, I have item 10, other matters requiring board discussion, updates, deliberations, and action and or approval. The first one is the appointment or reappointment of J.R. Labby to represent the hospital district for the city of Arlington, Tiz Place 4 Downtown Entertainment District and Viridian. If I could have a motion and a second to do that.
Mr. Chairman, I'd move for approval.
Second by Zim.
Discussion for anybody?
I'll double second that because I know JR loves those things.
It does have the word entertainment in it, though.
Just don't know who's mad.
If you're gonna double
second.
A, where do we get to B?
Yeah, I know.
All right. When A had a motion and a second and a super second. All in favor, please say aye.
Aye.
Those opposed say no. Hearing no no's, so to speak. Next is consider approval for appointment of J.R. Labby to represent the hospital district for the following city of North Richland Hills, TERS, Zone 1, 1A, and 2. Entertain a motion and a second.
Move for approval.
It's a second by Simmons.
All right.
And a super second by Steve.
All right.
That's what we were waiting for.
All right. Any discussion?
It's like double secret probation, right?
There you go.
Chuck.
In favor, please say aye.
Hold on, Chuck.
Uh-oh.
Chuck,
Yes, sir.
I need to abstain on B, please.
Okay.
Put that first together, so I don't need to vote on that.
Suzanne, did you get that?
Did. I've got it right here.
Yes, I got it.
Okay, thank you. All in favor, please say aye.
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 Those opposed say no. Motion carries. The next one is item C. Consider approval of the 2020 Community Health Needs Assessment Implementation Plan. Robert and Lauren Poe.
Let me introduce this, Dr. Weber, by telling you this is a follow-up. If you'll recall, at last meeting, Lauren Pope presented to y'all the requirements that we have by the IRS at submitting a community health needs assessment. this is an idea of, this is done by not only us, but it's done by all the area hospitals. Mr. Fisher asked a really valuable question at that time, and the question was, can't all you hospitals get together and sort of submit the same report? And the answer to that incredibly great question is no, unfortunately, because they stagger them and each individual institution does them at different times. Yes, Mr. Fisher, it would be exceptionally efficient if they did it differently, but they don't give us that option. So we submit ours. This is not the strategic plan. This is not the areas that we take our significant action in. You will see significant action as to how we interface with the community. Some of the concerns that Amanda Arizola has and others of you have, we will be submitting that in our strategic plan. This is pretty much just an assessment of what the community, where their needs are and where all hospitals can meet those needs. So Lauren, if you want to add anything to this, but Mr. Chair, we will need an approval. I know that most of you probably looked through this, but there is nothing of significant difference from when Lauren came and presented this in a briefing to y'all at last board meeting. But Lauren, anything that you want to add to this, you please do so at this time.
Perfect. Yeah, we'll just walk through a couple of slides. So I did have to just throw this up there. I'm in my office, but just for Steve, I wanted to make sure that he didn't have his Longhorn background. So Steve, since you didn't have yours, I figured I could go ahead and rival mine a little bit.
Ouch. Okay.
I can't. Oh, there we go.
Well, I took it down. But so as Robert mentioned, first of all, thank you, Chairman Weber, for allowing me to come back before you and talk through this information quickly. If you remember in December, like we talked at the board meeting at that time, that there's two big components to the CHNA. The first component is that assessment component, which is what you guys saw in December. The second piece of that component is the implementation plan. And so that's really what the discussion is today about, is the implementation plan. Again, that first piece is that assessment report that had data in it. It had different, if you remember, we had different data points that we walked through, qualitative, quantitative data, and then it really outlined what those key areas or needs were within the community. And then what the purpose of this second part required by the IRS again is that we take those 4 top identified needs that we presented to you in December, and we quickly just outlined then what the plan is for the next 3-year CHNA cycle. As Robert mentioned, this will require a vote of approval at the end of this. And so what you are approving is essentially what we're laying out before you over the next 5-7 minutes of what that high level plan is. Again, just as Robert mentioned, just remember this is not our strategic plan. Like he told you, we'll be spending the day tomorrow with the executive team, starting to kind of build the beginning phases of that plan to then come before you all in a couple of weeks after that. And so the information we talk about today, the information that we talked about in December, will come out in that plan. So you'll see that we'll build upon this information and include it in that plan, but it's not intended to be our strategic plan. So you can go ahead and flip to that first slide, and we'll just quickly walk through the information that you all will be voting on. So this slide is not new. We talked about this in December, but just to remind you, there are 4 components. The quantitative data, qualitative data, and priority model make up component 1 that we talked about in December. And then the implementation plan is what we'll talk about today, which is that 4th component. Next slide. So like we talked about in December, the quantitative and qualitative data that we reviewed as part of that assessment was combined together and categorized into several different areas of need, from maternal and child health, adolescent health, behavioral health, social, a bunch of different areas of need. That then was put into a priority model or a prioritization model, which is really an objective way to be able to evaluate all of those different areas of need, utilizing the different quantitative and qualitative data to determine which are the most significant needs. So I won't go through this, but there were 6 areas that the prioritization model looked at, and those are the 6 bullet points you see on your screen. You can go to the next slide. This is just a recap. We talked about this last month, but those 4 big areas of need that came out of that prioritization model were information and coordination, social influencers of health, chronic conditions, and then behavioral health and substance abuse. So next slide. So what we're really going to focus on, like I said, for the next couple of minutes is within each one of these 4 areas, you're going to see a slide that again outlines high level what we intend to do at JPS to address the needs per the IRS requirement. The one thing I will say is you're going to see it's very high level, and that's for a reason. Like Robert talked about, we're going to take this and the detail behind what we're about to talk about will come out in the strategic plan. We'll be very methodical about looking at zip codes and other things as we get into the strategic plan efforts. So when you hear this and you read this, you're going to see that it's high level, but that is very intentional. So with information and coordination, these bullet points on the first slide are just to remind you what the definition is of information and coordination. So this is health literacy, navigation efforts, etc. If you'll go to that next slide. So from the standpoint at JPS, again, what we quickly identified is that, obviously there's a big population of patients that continue to utilize the ED as their primary care setting. We know that. We have a lot of great work going on at JPS currently with several different teams working on that. And so really what we plan to do is to continue that great work that's currently going on and continue to extend that work so that we can make sure and navigate patients to a primary care setting that's outside of the ED so that they can continue to get ongoing preventative care. So that's really the big effort around information and coordination. Within this, of course, there's going to be navigation efforts, outreach efforts, as well as several other things that, again, will come out in the plan. Next slide. So, of course, within social influencers health, I know this was a hot topic that came up in several of your interviews as part of our strategic planning interviews with you all, as well as our executive team, and rightfully so. And so, again, social influencers of health, I mentioned this to several people. We had a great conversation, I believe Amanda and I, with the consultants, the strategic planning consultants, when we talked about this. We really want to say these are influencers. These are not drivers. So if prior to this you saw this as social drivers or determinants of health, we are really positioning that as influencers because we strongly believe that nothing should determine someone's health. So if you go to that next slide. Again, at a high level, what we know as an organization is that we need to do a better job of A, identifying these needs in our patient population, B, connecting the patients to those resources within the community to help then solve those needs. And so that at a high level is what we will be doing. We'll be ramping up our efforts to be able to screen for these needs and then building out our partnerships to then connect these patients with those things that they need to address the social influencers of health. Next slide. So chronic conditions, again, these, hypertension, heart disease, diabetes, but also what falls into this chronic conditions bucket is that health literacy and education and outreach and proactive prevention. So if you go to that next slide. What we, really identified internally is, of course, we have a population that we serve that has a high chronic disease need, but one of the biggest needs they have is education, and really education around those chronic diseases and outreach around prevention efforts related to those chronic diseases. So that is the nature of what we'll continue to focus on. We do a lot of great work around that today at JPS, but essentially we will continue those efforts and build those out further in the upcoming plan. And then finally, if you'll go to that next slide, behavioral health and substance abuse was the fourth community need. Again, this is just a range of things that kind of go under that behavioral health and substance abuse topic. But if you'll go to that last slide. So, what we've quickly identified too, and what we talk a lot about is we have a phenomenal behavioral health program here at JPS. We're so proud of it. I can't tell you and brag enough about the behavioral team that I have the pleasure and honor to work with every day. And they really, truly do. They're great at what they do and the best at what they do. But what we also know is we cannot be the only providers of behavioral health care to our community. It really does take partnership partnerships and it takes a village. And so really, our focus that we'll continue to expand out is increasing, of course, access to behavioral health and substance abuse services, but through partnerships, right? And through collaboration within the community to make sure that patients get those services that they need, where they need them and when they need them. So again, with that, I'll kind of close. I know that was high level. I know it was quick. You all have access to this report, I believe, in the board portal. This report does have to be public facing. So we will post it to the website just as soon as we get done with the board meeting today after the official vote and approval. It will go on the website. But the most important thing I just want to stress is, again, we're going to use this information. It doesn't stop here. I promise you that. You'll hear it as we talk through the upcoming strategic plan discussions. But I'll pause there, Mr. Chair. I'll open it up for questions. I'll be happy to answer anything. And I would just ask that for formal consideration by the board for the CHNA implementation plan as required by the IRS.
Thank you, Lauren.
I got a question.
Who was it?
It's Roger.
Yeah.
Lauren, so and Robert, thank you for the explanation as to why all hospitals don't do this at once, or at least in maybe a trauma area or whatever. But Lauren, does JPS and the other major healthcare systems around us, do they share and collaborate on their CHNAs? Are they public information? Do we have trouble getting the documents?
No, so that's a great question. We do collaborate, and they are public facing by IRS rule. They have to be. And so we're able to share within entities, of course. What you'll also see is, and I didn't mention it in detail, but if the report goes into this detail, one of the factors that we actually included in our prioritization model for determining what significant community needs were was whether or not it was already addressed by other health systems in our Tarrant County area. So that was one of the 6 criteria that I briefly touched on at the beginning of the presentation as part of that prioritization model. So if it was identified as a need, right, in another local healthcare organization, CHNA, but they chose to focus on it and address it, then it didn't get as many points in that prioritization model as a need that was already or that was not being addressed by another organization, because that then meant the community still had needs there that we could potentially focus on.
Do the social determinants of health, or the influencers, as you said, do they look the same in the other hospitals' CHNA analysis?
Absolutely, they do. The same, we use essentially the same source of data for the most part. We get our data from the same sources because they are, predominantly public-facing data sources. And so the same needs within those social influencers came up within THRs and Baylors. And they too are really, again, focusing their efforts around first and foremost identifying those needs, and then working together honestly as a network right within Tarrant County to build those partnerships and connect those patients appropriately.
Yeah, I mean, I don't mind so much that we have to do them separately in 3-year intervals at separate times. I think it's good. I just want to make sure that there's strong collaboration. I know we're all competing for the dollars, right? But we both have, or all the systems have, different constituencies that they serve. That's for sure.
Sure.
And I think that the collaboration is really, really important.
Sure. And the one thing I didn't mention, and so I apologize about this. So the North Texas, the DFW Hospital Council actually does have a committee, and they do a phenomenal job of helping to assemble that type of collaboration that you're speaking to, Roger. And so they actually have a committee on the DFW Hospital Council specifically focused around having a representative from all the hospital systems to make sure we are coordinating our CHNA efforts. So I apologize. I did forget to say that.
All right. Thank you very much.
Mm-hmm.
Anybody else have any comments for Lauren?
Mr. Chairman, if I may.
You bet.
Lauren, this is great. I wholeheartedly endorse everything you've identified. I think we all intuitively know that all these things matter and they're all appropriate. But it's nice to have them written in such a concise manner. So I applaud you for that. I think, identifying the needs is obviously very critical. our biggest challenge will be how we implement the change, how we implement programs to attend to those needs. And that's probably why we're all here, right? That's why we exist, is to attend to those needs. So I'm looking forward to seeing how this evolves and progresses going forward. In all my years of being involved with JPS, frankly, I've never looked at these needs assessments quite this way. So thank you for that.
And I want to, if I could, and thank you, Steve, for those comments. If I could at this point, I'd like to commend Lauren and her team. We had brought some consultants in, but no disrespect to consultants, but they're only as good as the expert staff that are working with them. And Lauren and her team did an excellent job at providing this. Timing was a little bit tough because she is knee-deep into the strategic plan. And if you think this report is good, you will be blown away by the strategic plan. I am really impressed and proud with how the team is working on it. They've really listened to y'all's interviews and our interviews and put together what I think is a really good package. But she's had dual roles of trying to get this report out to fit the IRS timing, and then she's never lost focus of the strategic plan. So I'm really proud of Lauren and her team. So thank you, Steve, for your kind words, rather. Sorry.
I appreciate that from both of you. Thank you.
Anybody else? I have one comment for you, Lauren. Is when I started going through these, when it came up on information and coordination, I was surprised to see that disparities and systemic racism were in this slide and not under the social determinants of health. And that's my only comment, is that works into our strategic plan and whatnot.
No, and that's great feedback for sure. And I think it can be categorized, 6 one way, half a dozen the other. I think from the consultant's perspective, it fit into that more of an access component. And the systemic racism sometimes plays into that access component, but you're exactly right. It can definitely fit into the social influencers as well.
Okay. Is there a motion and a second, and maybe a super second?
I'll move approval.
I'll second.
There's super second?
No, super second, Steve. Oh no,
Super second.
I am hurt.
Okay. Well, any discussion for Lauren? All in favor, please say aye.
Aye.
Right.
Those opposed say no. Motion passes, Lauren. Thank you very much.
Good job.
Thank you so much.
Good
Great
work.
job.
Good work.
Good work.
Next one I have is number 11 is the consent agenda, and all were discussed in board committee meetings. And if anybody wants to pull any of these off to talk about them, if not, I'd entertain a motion.
This is a move to approve.
Trent, second.
Any discussion? All in favor, please say aye.
Aye.
Those opposed say no. All the consent agenda passes. And that brings us to the report of legal counsel and or legal matters requiring discussion, update, action, or approval. Ms. Daphne Walker.
Thank you, Mr. Chairman. For the month of December, we had 39 contracts that were under 500,000, and for the month of January, we had 40. In my most recent quarterly discussion with the board officers, we did talk about that it might be good to give some just high-level information to the board around the types of contracts that fall into those buckets. So going forward, my report will include that information as well. But that's all I have for today.
Great, thank you. Anybody have any questions for Daphne? I don't think that's nothing that we need to act on. So on my agenda, I've got coming down to executive session. So if it's okay, everybody will exit the open session, and then 5 minutes later, let's go into the executive session. I have it as 2:04. Let's go back at 2:10.
All right.
How's that?
Good.
Dr. Weber, I think you need to give David Mendenhall just 1 second. David, do you need a second to come out of closed into live stream?
About 15 seconds, so hold on a second.
Yep.
Okay, hold on. All right, the guys were teed up, ready to go. So Dr. Weber, you are live in 3, 2, 1. You're live.
Okay, we're going to reconvene in open session for deliberation and interactions deemed necessary regarding any matter listed on the closed session agenda. Is that okay with everybody?
That's it.
Do we need a motion for that, Daphne?
No.
No.
The motions for the items that need to be approved, not a motion to move ahead.
Okay, so the first one I have is the resolution for the Magnolia law, with the resolution and that's the bylaw certificate of the secretary.
So, Dr. Weber, I'd like to make a motion that we adopt a resolution authorizing and approving the creation of the Tarrant County Hospital District Public Facility Corporation pursuant to Chapter 303 of the Texas Local Government Code to act on behalf of the Tarrant County Hospital District, approving a certificate of formation and bylaws related thereto, and resolving other matters in connection therewith.
All right, is there a second?
Have a second.
A second to the resolution?
Second.
Okay.
Is that
Charlie seconded it too.
And I'll super second.
okay? Any further discussion about it?
Dr. Weber, I didn't get, it was muffled. Who seconded the motion besides the super second?
I think Mr. Powell did before Mr. Wynn did. So I think the second is Mr. Powell. And then the super second by Mr. Montgomery and Mr. Wynn being supportive. I think that's the way it goes.
All right. Any further discussion? All in favor, please say aye.
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 Those opposed, say no. Ralph Waldo Emerson, this is the first meeting that we've ever had where you didn't say anything. I'm very surprised. I just hope that you're not ill.
No, I'm fine. This is my third meeting. I got another one in just a few minutes.
See, I must tell you how it intrigues me. You have a voice that nobody could mistake for anybody else. But yet, every time you get ready to say something to the board, you always say, well, this is Reverend Emerson. We got it. All right. The next thing I've got is the privileges. Cheryl?
Hi, thank you, Chairman Weber. I appreciate it. I'll just make a motion to approve the privileges packet as presented in executive session.
Steve Simmons, I'll second.
Steve Montgomery, second.
Super second, all right.
No, that would be a super second, Steve.
I'm losing control quickly here, Charlie. All right.
It's the pink tie, Chuck.
Yeah, I see. You got to remember, see, that tie looks gray to me. When you're ready,
thank you.
Colorblind.
I got to crap another meeting here in a second.
All right. That's it for me. Is there entertain a motion to adjourn if there's no further business?
For approval? To adjourn.
Ralph, this is your chance.
Second.
There we go.
There you go.
All in favor?
Did not break the record.
I withdraw my motion so Reverend Emerson can move approval.
Good meeting, Chuck. I got to get on another one.
We're done.
Thank you, Mr. Chairman.
Good.
Thanks, everybody.
Thank you, everybody.